Thank you, Dr. Rashmi, Dr. Sagar, Dr. Mala. I think she did justice to a very difficult topic in a very short period of time. We have over 700 viewers who are logged in and they're waiting to listen to our star speaker, Dr. Shyam Desai, sir. Can we have the screen shared, please? May I request Dr. Mala Srivastav to please introduce our distinguished speaker.
It's my pleasure and privilege to introduce the next speaker of the afternoon, Dr. Shyam Desai. Sir, I cannot see the this thing.
You cannot see the screen?
I cannot see the screen. Sir is a past president of Foxy. He's the past president of MOGS. He's the past president of IAGE. He's the president-elect of CEFOG. Sir has been professor of Maharashtra University, Wadia Hospital, Mumbai for more or less more than 25 years. We are eagerly waiting to listen from you, Dr. Desai, regarding your scientific deliberation on neuroprotection, our role as obstetrician. Over to you, sir.
Can you see the screen now?
Yes, sir. If you can go full screen, you can just hit the play button there. You can just hit cancel there.
Pardon? Play.
Preterm labor always is a dilemma both for the obstetrician and it's a nightmare for the patients. So whichever way we can help our patients, it's good for the patients as well as for the obstetrician. And definitely neuroprotection goes a long way in helping and managing our patients.
So I've got it as your screen sharing. Are you not able to see the slide?
We can see the slide, sir.
It's not full screen, unfortunately.
I just wanted to share a very fond memory of Dr. Shyam Desai. When I was doing my PG, I attended one conference where Shyam Desai was, everything in that conference, he was chaye hue the pure conference mein. And while having food, I just asked Dr. Shyam Desai, as a mentor or as a teacher, sir, how you can manage so many things? You arrange the conference, you teach the students, you go for academics, and you do also your private practice and teaching in the hospitals. And how you can manage all these things? So, sir responded only in one word. He patted upon my back and said, "Beta, passion, passion." That was the only word he told. The passion is everything, and we can see that he is so passionate about all the field of obstetrics and gynecology, and he is an excellent orator. Sir, screen is yours, please.
Okay, now can you see the screen?
Yes,
Yes,
sir.
sir.
Please go ahead.
Okay, okay. So now we'll start our deliberation. Now, how do I move the slides? That is the... Yeah. Is someone moving the slides for me? I don't know. Yeah. Now, who is moving it? The host?
Yes, sir. Tech support.
Okay, fine. So now, when I tell you, you change the slide. Okay.
Okay, sir.
All right. So we had a very nice talk from the previous speaker, Kahar, who said that preterm labor is something which the obstetrician really dreads. And there's so many consequences of preterm labor, especially for the neonate, that one should ideally try and prevent preterm labor. So find out the etiology, try and find out the cause, find out what is the underlying condition at the particular time when you see her, the state of the cervix, etc., and try and arrest preterm labor with the various means that she outlined. However, in spite of all your efforts, sometimes you are not able to control the preterm labor, and one has to allow the delivery to take place. Now, there are certain things that we can do even at that stage, and that is what we as obstetricians should be aware of and use the evidence-based literature that is available with us and try and get the best of the situation. Now, may I have the next slide, please? Okay. So what is neuroprotection? Because we want to protect the brain of the child, very, very preterm children, especially below the gestation age of 32 weeks, when the weight of the baby is approximately 1,500 grams or less. Neuroprotection is when we protect the harmful effects of preterm labor. And what are the harmful effects of preterm labor? Is that because of the stress of labor, because of the various hypoxic situations that might occur, there can be intraventricular hemorrhage that occurs. And that is the reason why we sometimes lose these babies. Now, if we lose the baby, it is indeed a tragic event. But what is even worse is, suppose the baby survives, there can be neurological problems or residual problems that can occur. And as a result of which, not only does the baby have a very, very difficult existence, but even the parents also find it an extremely distressing situation that they are under because of this early preterm labor and the harmful effects of the preterm labor. So therefore, we have to ideally try and prevent this intraventricular hemorrhage by giving them what is known as neuroprotection. So this neuroprotection is defined as the result in salvage, recovery, or regeneration of the nervous system, its cells, structure, and function. Now, the various events that lead to neuronal damage and cell death. One is there's an excessive glutamate-mediated neurotransmission, impaired voltage-sensitive sodium and calcium channel functioning, impaired GABA-mediated inhibition, and alterations in the acid-base balance. We won't go into the details of this, but if you are able to give neuroprotection, it is a practical and achievable target using the drugs that are already available to us and at present employed for limited indications. Now, next slide, please. So, birth before viability, that is 37 weeks of gestation, is the single most important determinant of adverse infant outcomes in terms of survival and quality of life. Globally, is the leading cause of perinatal and neonatal mortality and morbidity. We know that most of the perinatal problems occur because of the prematurity. Now, preterm infants are particularly vulnerable to complications, respiratory problems, difficulty in feeding, poor temperature control, and high risk of infection. So along with that, the problem of neurological problems is in addition. It is critical to address the determinants of poor outcomes and try and control them to achieve further reductions in child mortality. Next slide. Now, the most beneficial set of maternal interventions are those that are aimed at improving outcomes. And we have discussed already antenatal corticosteroids. The use of magnesium sulfate and antibiotic prophylaxis are the other interventions that are now well known. Next slide. Now, cerebral palsy is what we all dread, and that is caused by abnormal development of the brain or damage to the developing brain. And if you see the various causes that are listed over, genetic problems, infections, intrauterine, a fetal stroke. But what we are dealing with today is bleeding into the brain in the womb or as a newborn, giving rise to ventricular hemorrhage and neurological problems. Next slide. So cerebral palsy, we have already discussed. Approximately 45% of all cases of cerebral palsy are associated with preterm birth. And with the rate of cerebral palsy of neonatal survivors born at less than 28 weeks is almost 30 times higher as compared to infants born at term. You can imagine what is the implication of that preterm labor. And unfortunately, the incidence of cerebral palsy is increasing because we have an increase in early gestation survival. You have babies who are preterm at 26 weeks. With all the advances in neonatal care, we find that these babies are are somehow salvaged and they grow up and they find that there is a neurological deficit. Next slide, please. So cerebral palsy can affect movement, muscle tone, and motor skills. Next slide. Now, magnesium sulfate is a drug familiar in obstetrics and has been used in the management of eclamptic seizures since the early 1900s. We use it for our patients going up imminent eclamptics, those who have eclampsia, to make sure that we do not have a repeat of the epileptic seizure that accompanies eclampsia. The neuroprotective properties of magnesium in preterm infants was first observed by Nelson and Greta, who found that when magnesium sulfate was administered to these patients with preeclampsia and eclampsia, they found that the incidence of neurological problems in these babies was much less. So therefore, that gave us an inclination to use this for a problem of neurological problems in the baby itself. Next slide. So over the last decade, a large number of prospective randomized controlled trials have been conducted, because now it is very well established that this neuroprotective role for antenatal magnesium sulfate therapy given to women at risk for preterm birth for the preterm baby is now very well established. However, the number of women needed to be treated to benefit one single baby by avoiding cervical palsy is approximately 63. That means we have to administer this neuroprotection to 63 mothers or parturients in order to salvage one baby, but it is still worth it because you're able to still salvage that baby and make sure that it has no deficit. Next slide. Now, how does magnesium sulfate provide neuroprotection? So the entire mechanism is not very well understood. However, there are certain mechanisms that have been proposed. One is it stabilizes cerebral circulation by stabilizing blood pressure and normalizing cerebral blood flow. There's a prevention of excitatory injury by stabilization of neuronal membranes and blockade of excitatory neurotransmitters such as glutamate. And as a non-competitive NMDA receptor antagonist, it prevents excitotoxic calcium-induced injury. So it's all at the cellular level that magnesium sulfate acts, and therefore it is something that is really useful to us in order to prevent this catastrophe. Next slide, please. Now, I think we have just discussed this, so we'll go to the next slide. This is a diagrammatic approach to tell us that what are the various anions that are there on the inside the cell, outside the cell, extracellular. And we have found out that by giving magnesium sulfate, one can rectify all the deficits that occur when you have a situation of very, very preterm labor. Next slide. Now, the various dosage schedules have been outlined, and the optimal regimen of magnesium sulfate for fetal neuroprotection is an intravenous loading dose of 4 grams, administered slowly over 20 to 30 minutes, followed by a 1 gram per hour maintenance dose. So it is almost something similar to what we give it when we have our patient with eclampsia. We give them a loading dose, but that loading dose in our situation, eclampsia may be 4 grams in each buttock and subsequently followed by a maintenance dose. Now, you should continue this regimen until birth. So once the birth occurs, you can stop it. But suppose birth doesn't happen in the next 24 hours. After 24 hours of starting the magnesium sulfate, one should stop. When birth is planned, as for example, in an elective C-section, this magnesium sulfate should commence as close as possible to 4 hours before birth. So suppose your birth timing for the section is around 10 o'clock in the morning, then this magnesium sulfate drip should be started at around 6 o'clock in the morning. If delivery is planned or expected to occur sooner than 4 hours, for example, now she's already 3 centimeters and you start the magnesium drip, it is still worthwhile giving the magnesium as it is likely to be an advantage from administration as soon as you start administering the dose. Next slide. Now, there can be toxicity for magnesium sulfate. For example, there can be respiratory problems. There can be reflexes which are abolished, for example, the patella reflex. And therefore, one should not leave the the mother unattended. And even the baby can have sometimes a problem where you find that by giving magnesium sulfate, you might actually have a intrauterine fetal death as well. Now, the results of the various randomly controlled trials for the use of magnesium sulfate have been the subject of many systematic reviews. And many of them we can discuss as we go along. Next slide. Next slide, please. A recent study found that the total dose of 64 grams was associated with a maximum protective effect. But if you go to see, starting with the 4 grams loading dose, it is not likely that we'll reach 64 grams. In fact, in the largest RCT, the BEAM trial, with its loading dose of 6 grams initially, followed by a 2 gram per hour maintenance dose, would have totally given a total dose of around 50 grams. However, one never really reaches that level. And the results from systematic review showed that the most commonly used dosage of 4 grams bolus with 1 gram per hour maintenance did not increase neonatal mortality or unsuspected neonatal complications such as asphyxia, intestinal perforation, enterocolitis, and bleeding intolerance. Next slide. So the various trials that have been found out, one was the magnesium endpoint trial. So it's called the MAGNET 2002. Preterm labor patients between 24 and 34 weeks, 2 groups. On one you give tocolysis, the other you give a 4 grams bolus of magnesium sulfate, and you find out the results. There's 2 subsequent trials, the Australasian collaborative trial of magnesium sulfate in 2003 and the French pre-MAG study in 2007 did not demonstrate an increased mortality from magnesium use. Neither trial, however, yielded significant improvements in rates of cerebral palsy at 2 years. The ACTO magnesium sulfate trial did report a reduced rate of substantial motor dysfunction as defined by a gross motor function classification, level 2 or worse. Next. Next slide. Next slide, please. Okay, no. The benefit, no, sorry, the previous one. Now, the beneficial effects of antenatal magnesium sulfate study in 2008, and that is what we call as the BEAM trial, was one of the largest randomized controlled trials of magnesium sulfate involving more than 2,000 women with singleton or twin pregnancies between 24 to 31 weeks of gestation. The study demonstrated a significant reduction in moderate to severe cerebral palsy, as well as cerebral palsy overall. In addition to these 4 trials, the MAGPIE trial of 2002 was designed to assess whether magnesium sulfate prevented eclampsia in women with preeclampsia. Now, many of the participating centers were in developing countries and reported a comparatively higher pediatric mortality as compared to other studies. There was no significant reduction in the rates of cerebral palsy associated with antenatal magnesium sulfate exposure. So fortunately, we have not had too much of complications in the neonate following the administration of magnesium sulfate. Next slide. So various meta-analysis of these 5 trials, antenatal magnesium sulfate have been evaluated. And as I said earlier, the number of women needed to prevent 1 infant developing cerebral palsy is 63. Next slide. Now there is a long-term follow-up data from the pre-MAG cohort, and also they reported no significant difference in neuromotor, cognitive, or language ability. So with these 5 meta-analysis and an evaluation of cost effectiveness, they all support the use of magnesium sulfate as a neuroprotective agent. Next slide. So subsequent randomized controlled trials to assess the role of magnesium sulfate were also analyzed in a Cochrane review in 2009. They also strongly endorsed, the findings endorsed that there were benefits in administering magnesium sulfate to these patients. Next slide. So the ACOG, that is the American College of Obstetricians and Gynecologists, have recommended for neuroprotection magnesium sulfate before preterm birth reduces the risk of cerebral palsy in surviving infants. Next slide. Next slide, please. So many guidelines worldwide have plugged magnesium sulfate as an essential ingredient of daily best practice when managing inevitable preterm birth, because it has been definitely shown to reduce the risk of severe neurological deficit, in particular cerebral palsy. And the more premature they found, the greater benefit was the association with antenatal magnesium sulfate. Next slide. Now, we are concerned with what FIGO advises us, because FIGO is our international body. And FIGO guidelines also clearly recommend magnesium sulfate. And they recommend to say that in women at risk for early preterm imminent birth, from viability to 30 weeks of gestation, the use of magnesium sulfate is recommended. In pregnancies below 32 weeks to 34 weeks, the use of magnesium sulfate for neuroprotection of the fetus should be considered. Magnesium sulfate should be administered regardless of the cause of preterm birth and the number of babies in utero. And the optimal regimen of magnesium sulfate is what most of these studies were using, is that they give a loading dose of 4 grams slowly over 20 to 30 minutes, followed by a 1 gram per hour maintenance dose. And this should be continued until birth, but should be stopped if the patient is undelivered after 24 hours. Next slide, please. Now, at what gestation age should you give magnesium sulfate? Should you give it at 34 or 35 weeks? In fact, it's not really required at that time. So they said that in the Cochrane review of 2009, less than 34 weeks, the patient would have definite benefit, especially if they were less than 32 weeks or 30 weeks. Cerebral palsy is inversely related to gestational age, and therefore the absolute risk difference from treatment is likely to be larger at earlier gestations. So if you have a patient who's say 28 weeks or 29 weeks, less than 30 weeks, going into premature labor, think magnesium sulfate right from the beginning, because it will certainly give a lot of benefit to these babies. If the patient is already 32 weeks or more, the benefit is there, but it is not as much as it is in the earlier gestation. So the recommendation is in women at risk of early preterm imminent birth from viability to 30 weeks of gestation, magnesium sulfate for neuroprotection is recommended. Next slide, please. Now, what is the optimal timing? And in two out of the 4 trials included in the Cochrane review, they said that this magnesium sulfate should be given as about 4 hours before the actual delivery. And the recommendation should be this magnesium sulfate should be administered when early preterm birth is planned or expected within 24 hours. When the birth is planned, magnesium sulfate should commence as close as possible to 4 hours before birth. If delivery is planned or expected to occur sooner than 4 hours, magnesium sulfate should be administered, and there is still likely to be an advantage from administration at this time. Next slide, please. More or less the same points have been stressed over here. 4 grams loading dose and continue till 24 hours, even if she has not delivered, you stop it. Next slide. Now, there are certain subgroups that you have. For example, now we have a subgroup with premature rupture of membranes, or preeclampsia, or chorioamnionitis, or antepartum hemorrhage. So the Cochrane review included twins with 4 trials, including high-order multiples, and showed benefits in the administration of magnesium sulfate. So magnesium sulfate, they say, it should be used for neuroprotection of the fetus, regardless of the cause of preterm birth and the number of babies in utero. So certainly use magnesium sulfate. It will do only good rather than harm. Next slide. So as I said, that magnesium sulfate, if unsupervised, can cause problems. In the mother, there may be flushing, sweating, sensation of warmth due to its peripheral vasodilator effects when infused intravenously. Besides that, nausea, vomiting, and headache, and sometimes palpitations and pulmonary edema can also occur. So therefore, monitor these women for magnesium toxicity and make sure that you record the pulse, the blood pressure, and respiratory rate, and deep tendon reflexes such as the patella reflex. Next slide. Now, the WHO also has given similar recommendations, and rather than repeating it, I think we'll go on to the conclusion now. Next slide, please. Next slide. Next slide. Next slide. So these are all things which are on the FIGO as well as WHO have endorsed. Next slide. Next slide. Okay, so now we conclude this particular discussion on magnesium sulfate for preterm labor by saying that in women at risk for early preterm labor from viability to 30 weeks of gestation, magnesium sulfate, you've gone one slide earlier. Use of magnesium sulfate for neuroprotection of the fetus is recommended. Magnesium sulfate should be administered regardless of the cause of preterm birth and the number of babies in utero. Next slide. It should be considered as an adjunct to hypothermia, which is with its inherent advantages of widespread availability, low cost, and good safety profile. Some of the pediatricians prefer that when there is a chance of neurological deficit, they administer hypothermia to these neonates and thereby reduce the chances of intraventricular hemorrhage. So magnesium sulfate is in addition to this particular hypothermia that they may be administering. It has been extensively evaluated in a number of different neurological disorders across all age groups, from preterm to the elderly subject, and evidence of benefit appears most convincing in fetal neuroprotection, possibly due to the increased susceptibility of the immature brain to excitotoxicity and increased infective and inflammatory risks associated with prematurity. Next slide. Now, unfortunately, it has been very well accepted all over the world, and they are implementing it also in various labor rooms and neonatal setups all across the world. Unfortunately, in India, we do not have this acceptance of this particular modality to that extent. Our residents should be taught that, well, whenever there's a patient with preterm labor, think of your antenatal corticosteroids. Also think of tocolysis just to delay so that you can have the benefit of the corticosteroids. But you must also think of magnesium sulfate, because this magnesium sulfate administration can drastically improve the chances of cerebral palsy in the surviving infants. Next slide. I thank you all for a very patient hearing, and I hope my elaboration of this topic has brought out the fact that magnesium sulfate is indeed a very useful agent, and one should accept it with open arms and make widespread use of the drug. Thank you.
Thanks, sir. You have nicely covered the importance of neuroprotection in preterm labor, and you have quoted various studies in favor of your statement. You have stated about time of giving max sulfate, period of gestation, and the regimen, dosage. Everything has been very nicely and comprehensively covered by you. True, sir, you are a great teacher, teacher of teachers, and definitely a very passionate teacher. And we are very lucky to hear from you the way you have told that all the residents should be sensitized about preterm labor, the problems of preterm labor, both to the mother as well as to the fetus, and how to do neuroprotection and steroid cover to have a healthy baby at the end of each delivery. Thank you, sir. I must thank Dr. Pratik Tambe to have given us this opportunity to attend this.
I thank Dr. Pratik Tambe too for very enthusiastically pursuing his chairmanship, and I'm sure he'll be a good asset to the federation and the fraternity with all his efforts. Thank you, Pratik.
Thank you very much, sir. Thank you, respected chairpersons, for doing a fantastic job. At the end, sir said that there needs to be greater awareness in India amongst our residents and amongst our teaching staff as well regarding the utility of magnesium sulfate, specifically for fetal neuroprotection. I have a couple of slides which I'd like to share, and they are specifically regarding clinical trials conducted in India. So with your permission, I'll try and share these. This is specifically from India. Can you see the screen?
Yes.
All right. So this is 100 pregnant women who were given loading dose, etc., which was already described by Sir. And the infants who required mechanical ventilation was significantly less in the magnesium sulfate group. And also they found that the incidence of retinopathy and the other issues which occur in extreme prematurity was significantly lower in the magnesium sulfate group. This is from Chidambaram Medical College, 50 pregnant women who were given magnesium sulfate, and they found that the incidence of this Thompson score, 60% of the newborns had normal neural development, 38% had mild abnormalities. So most of the infants seem to do well when you have administered magnesium sulfate. Apgar scores are better, cerebral palsy is also lower, which Sir has already highlighted. And in fact, it's been found that intraventricular hemorrhages are also halved in infants where the mothers have been administered magnesium sulfate. So I think on the whole, there is plenty of evidence. This is actually a publication in our very own Jogi. So there is increasing evidence from India as well, which is coming. One last trial, this is from JAMA, of course, 1000 plus women. And again, the incidence of all these pediatric neurological abnormalities is significantly lower. The advantage with the new packaging that we have is that you have a single dose infusion, 4 grams in 100 ml, which can be given IV over 15 to 20 minutes. There's no need to dilute it. There is no need to search for whether it's 25% or 50%, which honestly is what used to confuse a lot of us when we were ourselves residents. The nurses used to get confused. We were also confused. Sometimes it turned out that it was 50%, sometimes it was 25%, and the wrong dosages used to go in. The advent of this single dose, easy to administer infusion, we can give the right dose in the patient, and you can also give a good maintenance dose to patients if you plug in your infusion pump. We have a few questions which have come in from the audience. We have over 700 viewers live logged in right now. I'll just take these questions with your permission.
Okay.
And the first question is from Dr. Prakash Tikwani from Ahmednagar. The question is, what is the minimum gestation period for the fetus to survive? Dr. Rashmi, you want to take that? I wish I knew the answer for that, but unfortunately, I don't know the answer.
I also wish I knew the exact answer for this question. So now with the advanced medicine and all our patients we are taking the medicines available and the interventions, the lower limit of the surviving fetus has come up to 21 weeks, and from 21 weeks to 25 weeks is the critical period. This is the period of actually we have this moral, ethical, and medical dilemmas when the delivery occurs in this period. But yes, of course, from 25 weeks onwards, we have a clear mandate that we should be able to offer all the active management so that we can save the baby, because now we have extremely good neonatal facilities, and of course we can save the baby from 25 weeks gestation onward. But we can't say same about the composite medical complications that are going to occur in the extreme prematurity.
I'd like to also add a comment.
Yes, sir.
The Calcutta conference, All India conference in January, Patrick O'Brien, who's in King's College in London, he said that up to 25 weeks they have found that there is a fairly good chance of the baby having a normal life if we are able to salvage the baby. He says prior to 25 weeks, he says there are too many deficits, and ideally one should not try and resuscitate these babies.
Thank you, sir. I think the age of viability, so to speak, varies from institution to institution and depending on the comorbidities that the fetus comes with. Obviously, a baby who's born extreme premature, as both our excellent speakers have already pointed out, is going to have a lot of deficits, and that is going to result in a lower salvageability. But having said that, we should try our best to try and salvage every fetus which is possible. Work in close association with the neonatologists and the pediatricians who are going to look after the baby. Don't just hand over the baby at birth. Make sure they are well informed in advance so that they can prepare accordingly. Often it happens that at the time of the delivery, when the baby is being delivered, that is the first time the pediatrician knows that such an extreme premature baby is coming. That's not pardonable in today's world anymore. The next question is from Dr. Savai Madhupur asking, what are the investigations which can reliably predict preterm labor? I think Dr. Lakshmi has already addressed part of this question earlier. You want to take that, ma'am?
Yes, in short, we can say that we can identify the group like if there is previous history of spontaneous labor. And this is the very primary high risk factor. And when there is the previous history of spontaneous preterm birth in a patient, she will have 15% more risk of preterm labor in her next delivery. Then with this history, if she is having a short cervical length, less than 25 millimeters, 14 to 24 weeks of gestation, she will have more chances of having a preterm labor. So at this time, at this point of time, what an obstetrician can do, she can invest 5 minutes more during the time of the anatomical scan and do a transvaginal sonographic determination of cervical length and monitor her accordingly bi-weekly so that we can intervene early and prevent preterm labor. So in my opinion, previous history of spontaneous labor and short cervix, with this history, short cervix less than 25 millimeters at 14 to 18 weeks of gestation is a very strong indicator for preterm labor.
Thank you, ma'am. Dr. Sagar, you wanted to say something, sir? You're muted, sir.
I just wanted to ask a question to Dr. Shyam Desai, sir.
Yeah.
In our area, we are practicing giving Maxhelp up to 32 completed weeks. But in many studies, it has been said that it should be given up to 34 weeks. So what is your advice, sir?
I think if one can, administer magnesium sulfate to these premature babies, premature labors of even 34 weeks, one should administer because it won't do any harm. Many of these studies have shown that the babies are able to tolerate that dose quite well. And it will help your neonatal setup over there to send more babies home. So even if the baby is, patient is less than 34 weeks, I would administer.
Thank you, sir. One last question we'll take, and this is regarding the success rate in stopping established preterm labor. This question is from Dr. Alok from Kalyani in West Bengal. So anybody can take that.
So I think we cannot definitely say what is the exact amount of success rate after stopping the preterm labor. When we talk about the preterm labor, I want to say that we have to, what can be useful in stopping the preterm labor should not be the primary question. My opinion is a primary question should be why there is preterm labor. And there could be in the background so many factors that are causing the preterm labor and which have to decide at this point. So if we go on extremely treating the patient to stop the preterm labor and the baby is trying to come out of the uterus. So are there any intrauterine factors that those are suggesting that the ex utero life would be better for the fetus and is trying to come out of the intrauterine environment? So more than what are the factors that are going to help why the patient is having preterm labor and analyzing it for individual patients is go a long way in treating.
Thank you. Thank you so much. The last count live audience is 982 logins, which is almost 1,000, keeping on par with the previous programs in the experience series. So thank you very much, audience, for being with us.
Congratulations on the very successful
Congratulations to all of us as well. Any closing remarks from the chairpersons before I present the formal vote of thanks, please? Dr. Mala, Dr. Sagar, anything further you would like to add?
It was definitely a very wonderful session for a general gynecologist practicing anywhere in the nooks and corners of Maharashtra. There was a very crystal clear message given by both the speakers, and take-home messages were very wonderful. And hearing Dr. Shyam Desai in his crisp voice was really music to our ears. So that's all from me.
Thank you, Sagar.
Thank you very much, Dr. Sagar.
Thanks, Dr.
Thank you,
Pratik.
Dr. Mala, madam.
It was a great opportunity for me to be a part of your program. And definitely Dr. Rashmi, she gave a very good messages regarding the risk factors for preterm labor. Preterm labor definitely is a great health problem for all of the practicing obstetrician. So the risk factors, madam said, how to deal with it, how to control it, and how to prevent it. That was the great messages from Dr. Rashmi in crisp lines. And of course, it was a pleasure to be hearing Dr. Shyam Desai, who's a teacher of teacher and a great teacher, and he nicely outlined the importance of MagSurf and how it does neuroprotection. And I'm sure each and every one who is present here and listening to this program has benefited enough from this program. Thanks, everyone. And may I have the more opportunities to attend these programs in future as well.
Thank you, Dr. Mala. Dr. Sagar, thank you very much for gracing the occasion. So at the end of today's event, I would like to present the formal vote of thanks. On behalf of the AMOGS Endocrinology Committee, for which I'm the chairperson, Dr. Pratik Tambe, I'd like to pay my respects to Dr. Rajendra Singh Pardeshi, our president of AMOGS, Dr. Srijata Darvi, our secretary of AMOGS, the ICOG office bearers, our chairperson, Dr. Lakshmi Shikhande, Secretary ICOG, Dr. Ashok Kumar. Thank you for the credit points for this program as well as all the other programs in the experience series. Thank you, Dr. Sagar Kataria, Zonal Coordinator of AMOGS, and Dr. Mala Srivastav, my co-governing council member of ICOG. Thank you very much for your very valuable remarks and feedback. Thank you for being here with us. Two excellent talks by two very stalwart speakers, Dr. Lakshmi Kahar, who's the chair for the AMOGS IRIS Pregnancy Committee, and our teacher of teachers, Dr. Shyam Desai, sir, past president of FOXI and AMOGS. Thank you very much for being with us, all of you in the audience. My gratitude to Science Integra, Subbu, Sana, Ganesh, and today I think Aparna is here with us for the first time. Thank you very much for being our backbone. And last but not least, to Blesson Pharma, the makers of IVM carbicin and injection I3. Thank you for being our academic partners throughout this journey. We look forward to seeing the audience in the next event. So until next time, goodbye, God bless, and take care. Thank you very much for
Thank you very much, sir. It was a great honor.
Thank you, Pratik, on behalf of all the listeners that you are putting this wonderful series of webinars, and these are very useful talks. Thank you.
Thank you, sir. Thank you so much. Bye.
Bye.
So he's the Sagar sir, Dr. Pratik sir, he is the great academician of our times.
Thank you. So sweet.
He is.
Thank you very much.